This conference will now be recorded.
Good morning, everyone. In previous classes, we have discussed regarding, presented the seminars regarding alcoholic liver disease, acute pancreatitis, gastroesophageal reflux disease. Apart from all the three, that gastroesophageal reflux disease is a different entity from the above two, that is alcoholic liver disease and acute pancreatitis, because these two are both closely related with one another based on the etiological agent. Now today, cirrhosis of liver, this is another important essay question as well as the practical purpose theory and viva both. It's very, very important in your final year examinations, both in the theoretical aspect as well as the practical aspect. So before going to the topic in proper, why we should know the cirrhosis of liver means, because in the previous class we have discussed again alcoholic liver disease. So in a brief, just in a brief review, these kinds of stage of fatty degeneration, three stages. That is the final stage, that is the cirrhosis of liver. In that alcoholic liver disease, there is a spectrum, three spectrum. Among the three spectrum, that is stage of fatty liver, alcoholic steatohepatitis, and the stage of fibrosis, that is nothing but the cirrhosis. So this is among the third stage. If the alcoholic patient, that is a chronic abuse of alcohol, if keeps on consuming the alcohol in a duration of about 10 to 20 years, with exceeding the threshold or the frequency of the consumption, then the final stage that the patient may land into the cirrhosis of liver. So that's why important is, because this is the end stage, like end stage kidney disease, like that we will be terming this as like an analogy, not in exactly, but we can get congruence in an analogy. It may be the end stage liver disease. So like that you can compare with the end stage kidney disease, like how will be compared the stage. Initially the patient will be an acute kidney injury, then a repeated episode in a duration of the over a period of in case of chronic diabetes for a duration of 10 years, then he may be landing into chronic kidney disease, and chronic kidney disease may further he may get deteriorated and its GFR may not improve. So that is the end stage kidney disease, like diabetes nephropathy. There is a in the end stage kidney disease. Likewise, the cirrhosis of liver is we can consider it as an analogy like end stage liver disease. So what happens in the cirrhosis of liver? Today's topic of interest is this cirrhosis of liver, how the patient present to us, because all the patients may not be present to us in the stage of fatty liver or the stage of steatohepatitis. Some patients may get because of the lack of money or like this, or because of the lack of knowledge or anything. The two stages may be skipped. That means the patient may not be aware of the two stages. Initially, in the stage of like fatty liver, he may be having a pain in the right hypochondrium, but he may skip it, thinking that it's like a vague abdominal pain, like he will be considering it as a vague abdominal pain. That's why he will be not that sure. And then followed with the stage of steatohepatitis, that you will be presenting like the fever. In that stage, you will be presenting like yellow discoloration of the skin, and you'll be presenting like fever. In that two cases, similarly, in that case also, you may get ignored, or you may get you may not be that emergent to go to the hospital, or you may get admission. So in these patients, these two stages may be skipped in this case. So finally, at the time of arrival to the hospital or any casualty or the emergency ward, this patient directly may present with us in these features of the cirrhosis level. So today's topic of interest is what is the clinical features of cirrhosis, what is its pathogenesis, and how will we investigate the case, and how will we manage the case, and what are the important complications. Among the complications, several complications will be there, but our topic of interest that the two complications among the cirrhosis, that the most common complications, that is portal hypertension and hepatic encephalopathy. Remember the two topics, portal hypertension and hepatic encephalopathy, I will be like dealing with very in a brief manner, because these two topics should be dealt again in the further classes with in a very detailed way. So just follow kindly, this portal hypertension and hepatic encephalopathy are included in this topic because these two share a very important role in these complications. So because most of the complications of cirrhosis of liver, these two are the most common. So you should know the important complication these two and how will we manage the case. So going to the topic in detail. So what is the definition of cirrhosis? So what is cirrhosis? So it is the third stage of the alcoholic liver disease, that is spectrum. That is initially the stage of fatty liver, that is stage of steatohepatitis, and the stage of fibrosis or cirrhosis. So what is cirrhosis? It is a Greek word. It means keros means orange or tawny, and osis means condition. So this is an orange or tawny condition, but according to the World Health Organization, a diffuse process characterized by liver necrosis and fibrosis and conversion of normal liver architecture into structurally abnormal nodules that lack normal lobular organization. So here we can see this is the normal liver. So you can see the soft in nature, that is a surface appear to be regular without any irregularities, but here you can see the nodular appearance. So that is what the definition is here. Here you can see the nodular appearance, as well as you can see the surface or the margins, you can see the irregular nature. So we cannot comment on this whether it is a firm or like that. So just you can by the image view, you can just appreciate the here is continuously it's a regular borders having regular and very soft in here. So you can see regular margins and smooth surface like appearance, but here you can see the irregular or the nodular like appearance and the see the nodular structures. So this is a image regarding cirrhosis. So coming to the causes, that is the etiology of cirrhosis. So what conditions that may land into the cirrhosis, or what are the precipitating factors, or what are the toxic conditions, or what are the causative organisms or the causative agents or the something that all that may lead to the cirrhosis means. But coming to the first and foremost that is important is post hepatic cirrhosis, that is hepatitis B, D and C infections, that hepatitis virus infections that may lead to cirrhosis. And the second is toxins. Toxins mean alcohol. As I mentioned earlier, that is alcoholic, because alcoholic liver disease, the spectrum itself is this cirrhosis. There is a chronic consumption of alcohol that may lead to the cirrhosis. So remember this one. Alcohol is very important. Other than alcohol, in case of IVI, they ask the questions like, what are the other conditions that may lead to the cirrhosis? Then you have to mention the other conditions like hepatitis B, C, and also you should mention like polycystic liver disease, primary biliary cholangitis, and primary sclerosing cholangitis, and autoimmune diseases like autoimmune hepatitis. And coming to the vascular disorders, what are the vascular disorders that may cause cirrhosis means that cardiac cirrhosis, Buerger syndrome, veno-occlusive diseases, and coming to the metabolic causes, that is Wilson's disease. This is very important. How the Wilson disease? What is Wilson disease? This is nothing but ATP7 transporter chain defect. So because of this, disturbance is coming to the metabolic and genetic causes, that is the Wilson's disease. So what is this Wilson's disease exactly is? Wilson's disease is nothing but ATP7 gene defect in the transporter chain that leads to the improper copper absorption. Copper transport defect, because of this there will be excess accumulation of the copper within the hepatocytes, leading to the damage of the hepatocytes. So next important causes of that is metabolic and genetic causes is hematochromatosis, alpha-1 antitrypsin.
Enter, sir.
Position of iron within the that is ferritin within the hepatocytes, and the another one is alpha antitrypsin deficiency. Remember this alpha and 1 antitrypsin deficiency. This is the most common cause, especially in children. In children, this alpha 1 antitrypsin deficiency is most commonly seen. And the next one is the non-alcoholic steatohepatitis. So because this is also one of the important entity, because this NASH, that is non-alcoholic steatohepatitis, as well as alcoholic liver disease, this spectrum, if we consider the histopathological aspects of the tissue, this both appears to be same. We cannot differentiate between these two, alcoholic spectrum and non-alcoholic steatohepatitis. The only difference is the clinical entity. These patients may alcoholic liver disease. These people will give a classical history that I'm a chronic alcohol. But whereas this non-alcoholic state hepatitis patient, this say, sir, I never used to consume any alcohol, or there may neither history in our family regarding any genetic aspects. But how so in these patients, how this patient may develop because of like chronic conditions like diabetes. This may also may cause non-alcoholic steatohepatitis. So next, coming to the pathology of the cirrhosis, how the exact pathology is, see, as I mentioned in the definition itself, there will be nodularity. So that nodularity is nothing but they are regenerating nodules. And fibrosis, the fibrosis is nothing but the deposition of dense fibrous sample, that is fragment of sample, and the liver architecture, distorted liver architecture. And coming to the hepatocytic proper, that is pleomorphism, that it may exhibit dysplasia. That is, dysplasia means there may be hyperplasia, hypoplasia, something, anything may occur. That is hyperplasia. And if you see the gross pathology, that is on naked eye appearance, how these specimens look like is they will be having the irregular surface. That irregular surface itself confirms that this is not normal. That is, will be no smooth surface appearance. There will be irregular, the margins will be irregular. On appearance, you will be like seeing that yellowish discoloration. And if you see the consistency, that the consistency there may be firm. Don't get confused. The firm means it may have, is there any carcinomatous changes? No. If you it means that we will be stony hard in consistency. We will be mentioning that in case of hepatocellular carcinoma, the consistency of the nodules will be stony hard. So coming to the differences between here the normal histopathology, we are compared to the cirrhosis of the patient. See here the large irregular nodules. These are the nodules surrounded by here. See, you can see the fibrosis. This entire gets fibrosed. So this is the pathology in cirrhosis. See, can you appreciate here clearly? This is entire one is the regenerating nodules, and here you can see the fibrous tissue surrounding the regenerating nodules. And you can see the hepatocytes. That's complete. These all the hepatocyte structure gets distorted. That is, the liver architecture gets distorted. These are the pathological features. See here, you can see the fibrosis. Here you can see the regenerated nodules and complete distorted. See, in the previous image, you can see the architecture is maintained here. Their central lobular vein surrounded by these hepatocytes, array of hepatocytes you can see. But here, the complete distorted architecture of the liver can be appreciated. So here you can see the normal sinusoid, hepatic sinusoid. Here the fenestrations. These are the retinoid complex. Hepatic stellate cells. Here you can see the appreciate the space of the sinusoidal endothelial cells, and the hepatocytes. See here, but in this case, you can see the alteration in the microvascular in cirrhosis. See, because of this activation of the stellate cells, collagen deposition that is in the space of this is the final leading into the fibrosis, and the constriction of the sinusoid, this gets distorted, and the defenestration of the sinusoids. So what is the natural history of the chronic liver diseases? As I mentioned earlier, that is alcoholic liver disease, that is chronic liver disease. Compensated. What is meant by compensated? In this case, compensated cirrhosis means the end stage complications like varicose hemorrhage, ascites, encephalopathy, portal hypertension, jaundice. If these complications are not developed, then means that we will be saying that the patient is in compensation. That is, these are without any end stage disease complications. If the patient develops these complications, that is variceal hemorrhage, ascites, encephalopathy features like daytime somnolence, asterixis, huge shouts, the patient may not be behaving like arrogantly, and if they develop jaundice, all these features, then it is called as decompensated cirrhosis. So in this condition, the patient may finally they may lead into death or may land into morbidity. So next coming to the clinical features, how the patient. So how you should pick up the patient is in the stage of the how you should come to the conclusion that the patient is an alcoholic liver disease or as I mentioned earlier the previous slides, that is cause of cirrhosis, that is toxins like alcohol or any hepatitis B infection, hepatitis C infection, or any alpha antitrypsin deficiency, or any cases of Wilson's disease, hematochromatosis, or any drug history. So because with that history, you can just come to a conclusion that maybe this may be the etiological agent for the present condition. But before you're coming to the conclusion, you should know the proper history. So whether the patient is having any alcohol history or not, or any drug history or any chronic conditions or any something, you have to in detail you have to evaluate the case regarding the history. Then after the proper history taking, then you should come to the know how the patient presented to you. So all these conditions, how the patient of cirrhosis will come to or present to you. So first, if you on examination, if you see the patient may have hepatomegaly, so there may be because so you may have a stage of one doubt that sir, in cirrhosis the liver gets shrunken, now how we will get hepatomegaly. So in this initially there may be gross macronodular. So again in this cirrhosis we will have macronodular or micronodular. If the patient in the initial stage of cirrhosis, there may be hepatomegaly. So when the cirrhosis keeps on, the patient is getting not getting treated or something, or this disease getting progress, then the patient may have like micronodular cirrhosis and then shrunken liver. Then the hepatomegaly may not be appreciated. So another features like ascites. So why the ascites? Because of this distorted architecture as well as the constriction of the sinusoids, all the vasculature within the sinusoids and everything, this gets constricted. As a result, the back pressure. Back pressure means in the portal vein, what happens is the portal vein, the hypertension, the pressure increases. So because of this pressure, what happens? The exudation of fluid exudates, and that leading to the formation of ascites. So in proper, we will see the next at the top in the portal hypertension. I will explain how this ascites develops, and if there is circulatory changes, then the development spider telangiectasia, there will be palmar erythema. If you see the palms of the patient, there will be like reddish discoloration of the skin. You can clearly appreciate. And if there will be cyanosis. And coming to the, these are all the related to the liver changes. So coming to the endocrine changes, there will be loss of libido. That is there will drives for the sex. That is drives regarding the sex drive. In this patient it get decreased, and there will be pubic hair loss. In the case of men, you can appreciate gynecomastia, testicular atrophy, and impotence. These are the three sexual characters that may get affected. The three conditions that seen in the case of men, that is gynecomastia, testicular atrophy, impotence. So remember, all these clinical features of cirrhosis is very, very important for both the practical purpose, that is viva purpose, as well as the theoretical aspects and also practical purpose. It's very, very important. Every patient, every student they may be asked regarding these clinical features in the viva. So here we can again, once again I'm repeating that is ascites, circulatory changes, spider telangiectasia, palmar erythema, cyanosis, and coming to the endocrinological changes, that is loss of libido, hair loss, men, that is in men, gynecomastia, testicular atrophy, impotence. In the case of women, there will be breast atrophy, irregular menses, and amenorrhea. And hemorrhagic tendency. Why these hemorrhages develop means because in the portal hypertension, what happens is in the case of cirrhosis, then immediately patient may land into portal hypertension, and because of this pressure within the portal vein, all this pancreatic circulation as well as the circulation within from the bowel, all this in the pressure will increases, and as a result there will be esophageal varices as well as the hemorrhoids. That hemorrhoid is nothing but the dilated hemorrhoidal veins. These veins get dilated, and there may sometimes because of the increasing pressure, and also in this case the patient, if the patient during at the time of defecation, if it gets strained, then what happens is these hemorrhoids get ruptured, and there will be frank bleed within the pan. That is that's what the patient will give history that sir, I'm having a fresh bleed when I'm defecating. So these patients will also be complaining severe pain. So this is hemorrhagic tendency, and also the bruises, purpura, epistaxis, and malaria, and portal hypertension, as I mentioned. In this portal hypertension, because within the pressure within the portal vein increases, what happens is the back pressure increases, and as a result, there will be splenomegaly, collateral vessels, varicose bleeding, fetor hypericus, and there will fetor hypericus. If we see this order of there will be bad odor. Bad odor will be producing from the mouth of the patient. And coming to the portosystemic, that is encephalopathy features, as I mentioned, that hepatic encephalopathy is one of the dreadful complications in the case of cirrhosis, and there will be pigmentation, distal clubbing. So, in short, see the complications of cirrhosis results from portal hypertension or liver insufficiency. See here. In the case of initially, there will be hepatomegaly, and the disease may get progressed, and as a result, there will be patient will be landing into the cirrhosis. And after that cirrhosis, these two conditions, as I'm focusing, why it is important. See, portal hypertension and this liver insufficiency. That is nothing but hepatic encephalopathy. These are the most common complications that the patient develops. So after the portal hypertension, because of the back pressure, what happens is the veins that is circulated that is in the esophagus as well as in the anus region, that there will be developing variceal hemorrhages and ascites. Because there will be long-standing fluid accumulation, what happens is there may be hepatorenal syndrome or spontaneous bacterial peritonitis. So what happens is hepatorenal syndrome, because of this ascites, there will be a decreased vascular flow. As a result, there will be decreased renal perfusion. What happens if there is renal perfusion? This is because there will be GFR, decrease in the GFR. As a result of decrease in GFR, the urine will be gets accumulated within the blood, and as a result, the patient will be landing into the prerenal AKI. So because as a result, because of this cirrhosis, from the cirrhosis there is portal hypertension, and from the portal hypertension there will be ascites, and because of this ascites there will be decreased renal flow, and further there will be damage to the kidney, and the patient will be landing with acute kidney injury. So this is a spectrum from the liver to the kidney. So that is why we are naming it as a hepatorenal syndrome. So because of the long standing, there will be the fluid, the ascitic fluid may gets infected, that is affected, the infected, that is spontaneous bacterial peritonitis. So coming to the liver insufficiency, there will be features like jaundice, because all the normal hepatocytes get distorted, so there will be no bilirubin metabolism. As a result, this patient will be presenting with the jaundice. And now coming to the encephalopathy. What is this encephalopathy means? Because the liver, what happens is there will be a glutamate and ammonium cycle within from the brain and liver. What happens is the cycle ammonium cycle will be there. Because of this, as ammonium handling it does not occur by the liver, what happens is these ammonium ions get accumulated within the brain parenchyma. When ammonium ions are not converted into the ammonia, which is non-toxic, that is ammonium ion is toxic, what happens is this damages the brain parenchymal cells. So because of this improper handling of the ammonia by the liver itself, these ammonium ions get accumulated within the brain parenchyma. As a result, these were very toxic to the cells. It's leading to the encephalopathy features, like this patient will be presenting like asterixis, that is flapping tremor asterixis, and he will be having like huge shouts, huge foul cry, and he will be like daytime somnolence will be daytime he will be sleeping, and nighttime he will be roaming around the wards like that. So these are all the features of the encephalopathy features. So how will we diagnose the case of cirrhosis is that is as I mentioned, the clinical features. Based on the clinical features, laboratory radiological evidence, that is whether that is micronodule, macronodule, and the liver biopsy. That is, as I mentioned, the regenerating nodules will be seen, and there will be fibrosis in the septa, and there will be not regenerating nodules, and there will be distorted architecture of the hepatocytes. So in whom should we suspect cirrhosis? So any patient with chronic liver disease, that is chronic abnormal aminotransferases and or alkaline phosphatase, or coming to on physical examination, what are the findings that may suggest that patient may be having cirrhosis? Are stigmata of chronic liver disease, that muscle wasting, vascular spiders, palmar erythema, palpable left lobe of the liver, small liver span, splenomegaly, signs of decompensation. As I mentioned earlier, that is jaundice, ascites, asterixis. So coming to the laboratory evidences that are suggestive of the cirrhosis are liver insufficiency, that is as liver function gets distorted, that is all the hepatocytes get distorted, there will be a low decreased synthesis of albumin. That is why there will be low albumin, that is less than 3.8 gram per deciliter, and there will be prolonged prothrombin time, that is international normalized ratio, that is more than 1.3, and there will be high bilirubin. Why there are high bilirubin? Because the hepatocyte will not be handling the bilirubin properly, because all the cells get distorted. So that's why there will be bilirubin level elevated, that is more than 1.5 milligram per deciliter. So coming to the portal hypertension, say, what happens here is platelet get distorted, there will be low platelet count, and when we compare the AST and ALT ratio, there will be more than 1. So these are the remember these are the laboratory evidence that we may conclude that patient is in the stage of cirrhosis. So here you can see the ultrasound abdomen picture, that is liver cirrhosis. The CT scan in the case of cirrhosis, that here you can see all this is all irregular. See, irregular surface, and here we can see appreciate that hypotensive areas like collaterals, and here the huge spleen, that splenomegaly. So up to now we have discussed regarding clinical features, pathological aspects, and investigation aspects. So how will we come to the diagnostic? So what is the protocol, that is the algorithm? So the patients with chronic liver disease, and the patient is having any one of the following, as I mentioned, that variceal hemorrhage, ascites, hepatic encephalopathy. If the patient is having all these features, then we'll go for liver biopsy, not necessary for the diagnosis of cirrhosis, only to rule out any other chronic conditions. So then if all the features are not present, then we'll see the physical findings that any enlarged left hepatic lobe, splenomegaly, stigma of chronic liver disease, and laboratory findings like thrombocytopenia, impaired hepatic synthesis function. If it's yes, then again the same. If there is all these features are not present, then radiological findings like small nodular liver, intra-abdominal collaterals, ascites, splenomegaly, colloids. If there is if all these features are not absent, again we'll go for liver biopsy. So these are all algorithm for the case of cirrhosis. So coming to the management, how will the management manage the case of cirrhosis? Specific treatment is improper some pre-cirrhotic lesions like Wilson's disease. So now coming management of cirrhosis is nothing but because once actually this liver has a beautiful thing is that it has regenerating capacity. So when it will be having regenerating capacity, if you negotiate or if you exclude the causative agents, that is in case of what are the causes that landed the patient in the cirrhosis, like toxins or any metabolic conditions like Wilson's disease, hemochromatosis, or any other conditions. If we identify the etiological agent and if we treat that specific condition, then this condition is reversible. But if the causative agent is not known and the patient is developed for in the patient has run into decompensated stage, then it is not reversible. Remember that thing. So we have to act initial stages, that is the stage of fatty liver and the stage of hepatitis only we should get intervened. Once the patient develops cirrhotic features, may not be in all the patients may not be get recovered. Just we can delay the process. So we may not simply get the stage may be, that may not be reverted. So the specific treatment in some pre-cirrhotic lesions like as I mentioned that Wilson's disease, then we should the treatment of choice that the drug of choice is D-penicillamine. In the case of hemochromatosis, that is because of this excess iron deposition within the liver condition, there will be phlebotomy. If we done the phlebotomy, that is nothing but through the vein will be there will be phlebotomy. Then I need
ట్యూషన్ లేదా ట్యూషన్ ఎందుకు లేదు వర్షం పడితే ట్యూషన్ ఉండదా గొడుగు వేసుకొని వెళ్ళాలి లేదా నేను ఇస్తాదా
like chronic for viral hepatitis, you will be given the pharmacological management, and in case of established cirrhosis, what happens is we have to treat the complications. So why I have mentioned that complications were important, because if you identify the complications, then if you treat the complications, the patient may get some relief. So in this case, what are the complications I mentioned earlier? Because that is the portal hypertension, jaundice, like the hepatic encephalopathy. So we have to screen for the hepatocellular carcinoma, because this is the end stage disease. The hepatocellular carcinoma is the end one. That is the last complication that the cirrhotic patient may have is the hepatocellular carcinoma. So immediately at the time of diagnosis only we have to go for the screening of the hepatocellular carcinoma, like any alpha fetoproteins, like for going for alpha fetoproteins, and in case if the liver biopsy is accessible, then we have to go for a biopsy and we have to confirm or we have to exclude the condition that hepatocellular carcinoma. So why it's important is because if the patient land into the hepatocellular carcinoma, the main mode of treatment is that is nothing but the liver transplantation and the maintenance of nutrition. Agendra, stuck in okay. So how will be the then? So next important thing is how will we. So this patient attendance will be what happens is the patients will be asking us for sir, will there be any advantage if we give the treatment, or how will the prognosis? So to know the prognosis, how the patient may get worse or may improve, to prognose a patient, so there we have a score that is child classification of prognosis in cirrhosis. That is this includes the variables like encephalopathy, bilirubin, albumin, prothrombin, and ascites. So if the score is based on these values, we will be scoring at 1, 2, and 3. So if all the individual scores, if we add on, if the score is less than A, then it is classified as child A, and if the score is between 7 to 9, that is child B, and if there is no more than 9, that is category C, that is which is having that worse prognosis. So another score is that is a model end stage liver disease score, that is 3.8 into serum bilirubin minus milligram in serum bilirubin, milligram plus 11.2 in INR plus 9. This is the how. So no need to remember this formula. Just remember this score, that is MELD score, that is model and stage liver disease score. So this is about, in brief, that is how cirrhosis. So what are the clinical features, pathological features, and what are the laboratory findings, and how will we manage the case in case of this, if the etiological agent is known. So this is one part of this discussion, and now the rest of the part is, that is, these are the complications. As I mentioned earlier before the class, initiating the class, that the complications, two complications, that is portal hypertension as well as the hepatic encephalopathy. Now we'll see in brief portal hypertension. Again, this class will be this regarding the portal hypertension. Another class will be taken, because it's very this is also an important short note as well as an essay question. This will be done again in a separate topic in a separate class. So just briefly, I will give the some points regarding portal hypertension. That is definition: it is an increase in the portal venous pressure. Normal portal pressure, that is 5 to 10 milligrams, is important. Remember this: the normal portal vein pressure is 5 to 10 milligram mercury. If there is more than, if the pressure exceeds more than 12 mm, then we will name it as portal hypertension. So normal portal blood flow is 1.1 to 1.5 liter per minute, and increased resistance to portal blood flow, hyperdynamic circulation, that's formation of portal systemic collaterals that divert the blood to the systemic circulation bypassing the liver. In this case, when the portal hypertension develops, these collaterals will appear, and these supply the blood to the rest of the part bypassing the liver. So coming to the mechanisms, you may not note this out, because see here, pressure results from the interaction, that is between R and F. Portal hypertension can result from increase in resistance to portal flow and increase in portal venous. No need to remember this, is for the slide. So here you can see the image. Here the normal lever, that is hepatic vein. You can see both the hepatic right and left hepatic vein. Here you can see the sinusoids. See here the splenic vein, combination of the splenic vein, and here the superior mesenteric vein, both will be joining and form the portal vein. From here again will be divided into the sinusoids, and from here they get right and left hepatic vein and the common hepatic vein. See what happens in the case of portal hypertension. If there is portal vein hypertension, see these collaterals will develop, because there will